august gathering of very eminent practitioners. My sincere thanks to my dear friend Dr. Anand for those very kind introductory words also. The topic for today's discussion is behavioral problems in chronic medical illnesses. And as we all know, chronic medical illnesses constitute a major share of the patient load which most of us practitioners see in our day-to-day practice. And they can include lifestyle-induced diseases ranging from diabetes to coronary artery disease, malignancies to neurological problems, and even chronic mental illnesses as well. So there are 4 or 5 very common behavioral problems which are seen in people with chronic medical illnesses. The first and foremost of them is depression. Depression is a common accompaniment of most chronic medical illnesses, and as per the evidence which is available from psychoneuroimmunology, depression will produce a problem with the immune response of the body, which can even lead to worsening of the basic medical condition. Again, there are a whole lot of anxiety disorders which also mimic various medical conditions and also occur comorbid along with various medical conditions. We have got somatic symptom disorders or somatization disorders as they used to be referred to earlier. Dramatic physical symptoms which cannot be explained by any medical illness, either by physical examination or by investigations. And we have got a 4th category, that is dissociative disorders. Again, very dramatic presentation of physical symptoms like seizure-like convulsion episodes, which does not have any electrophysiological problems in the brain, sudden loss of speech, and a whole lot of things like that. We have also got delirium, which is probably the most important behavioral problem that is seen in an intensive care unit setting. And during the COVID days, all of us could see a lot of patients in delirium suffering due to various reasons. And finally, the last one would be the behavioral and psychological symptoms of dementia, because India, especially Kerala, is supposed to be a population which is aging very fast, and quite a number of elderly people are there. And the statistics show that above 60 years of age, 5% almost is the prevalence of dementia, which doubles once in every 5 years. And if you take 85 plus people, around 50% are demented due to one reason or another. So let me start my presentation by discussing about depression. Depression, as we all know, is referred to as the common cold of psychiatry. A survey which was conducted by Kerala State Mental Health Authority in 2016 showed that 9% of the people of Kerala at that point of time suffered from major depressive disorder which warranted medical intervention. 1 in 5 of every female is likely to suffer from depression at any point of their lifetime. 1 in every 10 male may also suffer from depression. In India, most of the studies have shown that around 3 to 6% of the population is suffering from depression. And most importantly, 2.5% of the adolescents in India are suffering from depression. We should see it very seriously because the statistics of suicides which happened in the year 2021 showed that 13,000 adolescents from all over the world committed suicide in a single year. And probably unidentified, untreated depression could account for a large number of these 2 suicides. So what is depression? Is it normal sadness? Isn't it a response to usual stress which we come across in day-to-day life? Is it the sign of weakness? Because very recently I had a very interesting episode. I had gone to talk on the difference between male and female mind to a group of activists. Some of the very senior activists from different parts of India were there. I was talking about premenstrual dysphoric disorder and just mentioned that around 8% of females are likely to suffer from some sadness which may be more than the usual routine stuff. I described the symptoms and just mentioned that it could be premenstrual dysphoric disorder. Immediately one activist, a senior lady from Kerala, got up, raised her hands and told me that it is politically incorrect and highly insulting to females that you are speaking like this. I didn't know what had hit me. I asked her what offended you, and she told me that you should have told that 92% of females are strong. But instead of that, you told that 8% of females are weak. I could not understand again. So she explained further, telling me that depression or any mental disorder is perceived as weakness within inverted commas by the learned activist. As an answer to her question, I gave her an entire exhaustive list of Nobel Prize winners who had suffered from depression and probably bipolar disorder, and another list of actors, directors, and a whole lot of other celebrities who had suffered from depression, and asked her, do you think any of these people are weak? They are very strong people, and you and me are weak. And I winded up that discussion in that way. So, a lot of people think that lack of resilience or lack of ability to cope with day-to-day activities, that is the reason for depression. Inherently, it is a sign of weakness. It is not. So, depressive disorder has got 9 symptoms. If any 5 out of these 9 are present for 2 weeks continuously, that person is likely to suffer from a depressive episode. Continuous sadness from morning to evening, reduced interest in previously pleasurable activities, unexplained tiredness, sleep disturbance, classically early morning awakening. The person wakes up at least 2 hours before the usual time of his waking up. Reduced appetite, characterized by reduced interest in eating food materials which you used to devour very much in the past. Concentration impairment, characterized by difficulty in focusing on one particular stimulus or a thought, because a lot of thoughts are intruding into your conscious awareness like waves of an ocean. Psychomotor retardation or slowness in thoughts and actions, which is seen in majority of the people between 20 to 60 when they become depressed. But adolescent depression is characterized by psychomotor agitation, a feeling of subjective restlessness, an activity of pacing up and down in an uncomfortable manner, and inability to focus again. Depressive cognitions including hopelessness, helplessness, and worthlessness, and inappropriate guilt will be the 8th one. And 9th one is obviously death wishes and suicidal ideas. There is a phenomenon called atypical depression, which is now very commonly seen in adolescents, especially adolescent females. It is characterized by some of the reverse biological signs. Instead of sleep impairment, oversleeping, hypersomnolence, especially during the day, and many of them may be awake throughout the night, indulging in Netflix and a whole lot of other things. Of course, instead of lack of appetite, overeating or comfort eating or stress eating as we call it. Whenever you are stressed, you overeat. A family pack of ice cream is finished in an hour or even less than that to counter stress. And again, adolescent depression is much more lethal than depression at any other age, because in adolescent depression, along with strong depressive thoughts, there is psychomotor agitation. If a person is having psychomotor retardation, he or she is less likely to translate the suicidal ideas into actions. They are less likely to implement their suicidal ideas. And even if they implement, their lethargy and lack of physical energy may prevent them from attempting very lethal methods of suicide. But during adolescence, because there is psychomotor agitation, they are more likely to translate their suicidal thoughts to actions, and obviously much more lethal methods of suicide may be adopted, leading to very high rate of suicides among adolescents, even despite a lot of efforts to prevent suicides. Different kinds of depression: unipolar, bipolar, melancholic, dysthymic, psychotic. And in childhood depression, definitely, school refusal may be an important manifestation of depression. Of course, we see a lot of children who refuse to go to school for various reasons. Parental separation itself is one of the common reasons why they refuse to go to school. Obviously, this child at the age of 18 years is going to say that parental presence is the biggest stressor in his or her life. That also happens. So in childhood depression, clinging to an adult figure significantly and not leaving him or her off. Irritability again could be a manifestation of childhood depression. Instead of sadness, the child may be irritable, persistently irritable. And that irritability does not amount to frank violence. It starts as an irritability followed by probably crying spells, again leading to very loud noise. And of course, noise intolerance is a classical feature of childhood depression. Any child who says that he is unable to tolerate the noise of the television, or even somebody calling his name, or someone closing the door, is likely to suffer from depression. Adolescent depression is again characterized by frequent short duration anger outbursts, which are out of proportion to the stimulus. They may withdraw completely from adults, they may withdraw from their friends, and they may lock themselves in rooms for continuously several hours or even several days. You may think that the person is indulging in any sort of digital entertainment, like playing online games or something, but the child may not be doing anything at all. He may be remaining away from adults completely. Suicidal behavior, as we already discussed, is much more common in adolescent depression. And to counter the sadness and stress of depression, they may indulge in behavioral addiction. Behavioral addiction means doing a particular action, getting a pleasure out of it, and indulging in the same action again and again over extended periods of time to get the same degree of pleasure. So online gaming, porn addiction, social media addiction, dating app addiction, hundreds of ways in which adolescents try to counter depression through behavioral addiction. Even food addiction and sex addiction can be manifestations of behavioral addiction in adolescents. And of course, substance use as a self-medication to overcome depression, especially starting with tobacco, moving to cannabis, then meth, and a whole lot of other things. Depression in females, as I had talked to the group of activists, that can happen in 3 different situations in life: premenstrual dysphoria, postpartum depression, and postmenopausal depression. These are 3 specific times in the life of a female in which they are more prone to develop depression. Again, middle age crisis is a huge problem these days. Middle age, that is between 40 to 50, as it is said right now, it's the time in which most people may be spending time focusing on the future of the children, education of the children, and various problems created by adolescent children. All these add to the stress. Faulty methods of parenting will add on to that stress, precipitating depression. Physical problems, most of the lifestyle-induced diseases start during that age, and even sexual dysfunction starts in most people during that age. And to add on to all these, financial issues also play a major role. And geriatric depression, depression in elderly is also very common these days. And geriatric depression is characterized by cognitive impairment. Here, I may just introduce a terminology called mild behavioral impairment, or MBI. Dementia, which happens in most people after 65 years, is preceded often by a condition called mild cognitive impairment, or MCI. The features of MCI include difficulties in forgetting recently done activities, deficiency in working memory, difficulty in focusing, which may not amount to a full spectrum of dementia. But nowadays, studies have shown that even much before the onset of this MCI, there can be a phenomenon called MBI, mild behavioral impairment. Non-specific spurts of irritability, anxiety, disturbance in concentration, some transient hallucinations. All these things can happen much before the onset of cognitive impairment in dementia, and that is MBI. That is why it is said that any first onset behavioral problem happening after 60 years of age should be considered as a prodrome or a primer or a trailer of dementia unless otherwise proved. And you should follow them up or longitudinally to see whether they evolve into dementia in future. Emptiness syndrome is another very important phenomenon in our part of the world, where children are growing up, they relocate to distant places for their education or their future career. And most often in many of the homes, especially after the 2018 floods, when we had visited a lot of places in central Travancore, we could find huge mansions with elderly couple living alone, away from their children. And that can breed a little bit of sadness, and that is emptiness syndrome. And most of the studies which have been conducted in Western world have shown that in elderly people above 60 years of age, death of spouse is the biggest stressor. may be true to a large extent in our part of the world. So even though some studies have shown that death of a child when the parent is alive happens to be the biggest unparalleled stressor in our cultural context. Coping with medical illnesses is another very important problem, and of course, loneliness also. So coming back to our topic of depression, chronic medical illness, certain conditions in which depression can be very commonly seen include Parkinson's, dementia, cancer, coronary artery disease, and diabetes. So here, our diagnostic criteria of depression, when we go back to that, we can see that these are the 9 symptoms. Imagine a person who is diabetic and is on insulin, or a cancer patient or chemotherapy, or a recently diagnosed myocardial infarction who has a stent in situ very recently. Most of these people will have at least 4 of these symptoms in every single one of them. Most of these people will be having fatigue. We can't call it unexplained fatigue, but whether it is unexplained or explained, it is fatigue nevertheless. Sleep impairment due to pain itself is a major component of most of the chronic medical illnesses. Appetite disturbance is very frequent in any chronic medical condition, and of course concentration impairment. So these 4 symptoms, unexplained fatigue, sleep impairment, appetite impairment, and concentration impairment, they are not reliable to diagnose depression and chronic medical illness, because most of the people with chronic medical illness will have these 4. So one more symptom out of these and you may overdiagnose depression. So to avoid this overdiagnosis of depression, we have got a new criteria called Endicott's substitutive criteria. Here, instead of the 4 previously mentioned symptoms, lack of sleep, lack of concentration, lack of appetite, and fatigue, we substitute these 4 with new 4 symptoms. Brooding, remaining immersed in thought for a long period of time. Self-pity, lamenting about one's plight. Pessimism, a negative attitude about treatment, about illness, about the attitude of the doctors, caregivers, everything. This pessimism is supposed to be the single most important hindrance to adherence to medical treatment. The cancer patient who develops pessimism about treatment may break the chemotherapy cycle and may go after what you call magical religious treatment or spiritual therapies or alternate therapies, whatever it is. Of course, withdrawn behavior, a person who used to have a large social circle, once he develops depression, withdraws to oneself, refuses to give face to even visitors at home, finally gets confined to his own room, becomes wheelchair bound or bedridden. That is the phased way in which he cuts off from the external world. Fearful or tearful facial expression. There can be an expression of fear in the face. It could be fear of death. It could be fear regarding what would happen to the near ones, loved ones after their death, about financial issues, so many concerns. But certain conditions like Parkinsonism, the mask-like facies is very much there. But even in them, tearfulness, crying spells may be manifesting once in a while. And finally, non-reactive mood or inability to be cheered up. In an elderly person, no response, no emotional reaction even after seeing grandchild is almost a telltale sign that he is having depression. So what are the complications if depression is not properly treated in a person with chronic medical illness? Of course, chronic medical illness, especially cancer and depression, if the depression is not treated, possibility of suicide is very high. There is a condition called catatonia. It's a psychiatric emergency, literally, because the person will stop talking, stop taking medications and food, and refuse to take even fluids. And how long can a person survive like that? It is an emergency. It is one of the rare indications in modern psychiatry where electroconvulsive therapy will have to be resorted to prevent the person from dying. And of course, depression, if it is not properly treated, it can worsen the physical health of the person. So coming to the management of this, pharmacological management, psychological management, and social management, all of these are important. When we resort to pharmacological management, it is important to choose the drugs wisely. There was a very famous study which was conducted in 1970s called the cardiac arrhythmia suppression trial. It has nothing to do with cardiology. It was essentially a study regarding the efficacy of pharmacotherapy in post-myocardial infarction depression. People who developed depression after MI were treated with the only or probably the most popular antidepressant available at that point of time, the tricyclic antidepressants including imipramine and amitriptyline. Operation was highly successful, but most of the patients died. Depression improved, but many of the patients started collapsing and dying. And further investigation revealed that tricyclic antidepressants have got a property very similar to type 1A anti-arrhythmic drugs, the quinidine group of drugs. And if they are given without a clear indication, that can precipitate arrest and even death. So one message was very clear from the CAST trial. Never give tricyclic antidepressants in a person with compromised cardiac function. Then which can be given? That was the next question. Because most of the people believe that no antipsychotic or antidepressant should be given to a person with chronic medical illness. Then came another very landmark study, SAD heart, sertraline antidepressant heart trial. It was a study in which an SSRI, selective serotonin reuptake inhibitor called sertraline, was administered at a dose of 50 to 100 milligrams to people with post-MI depression. The results were wonderful in the sense that depression improved and the longevity of the patients also improved. And it was identified that sertraline, by virtue of its action on certain molecules like beta-2 thromboglobulin, it has got an anti-thrombotic action, which is very mild, not as much as the case of aspirin or clopidogrel or any of the renowned antiplatelet drugs, but definitely clinically significant. So administering sertraline, in addition to clearing depression, also provides a mild anti-thrombotic efficacy. Of course, it comes with, every effect comes with a side effect also. The problem is that because of the anti-thrombotic efficacy, if sertraline is combined with aspirin and given chance for gastric bleed, we have to keep in mind and probably have to take precautions for that also. Of course, there was another study called ENRICHED, ENRICHT. It was a study with escitalopram, another SSRI, which showed that similar results as of sertraline was here. So, to choose the SSRI of choice in a particular medical condition, we have to be aware of the CYP450 enzyme interactions. And most of the studies have shown that escitalopram does not have much interaction in CYP systems. It can be safely combined with any other drug. Fluoxetine, fluoxamine, and paroxetine, these three SSRIs have got significant interaction in CYP enzyme systems. For example, by virtue of the action on CYP1A2, fluoxetine, if it is combined with statins, fluoxetine can inhibit the metabolism of statins, leading to an increased serum level of statins and more adverse effects like rhabdomyolysis or muscle problems or even liver issues. Sertraline at a dose of 50 milligrams is devoid of any CYP issues, but if it is 100 milligrams or above, the same problem as fluoxetine surfaces. So like that with paroxetine and fluoxamine. So escitalopram happens to be a very safe option in that. Again, if it is a post-menopausal female with post-menopausal vasomotor symptoms, which is the drug of choice which can be given? That has been a very debated question. So SNRIs, because these are conditions in which the norepinephrine system is also at fault. So giving just an SSRI may not suffice. So something like venlafaxine or desvenlafaxine may be much more efficacious in this group of people because it addresses the physical symptoms including the vasomotor symptoms also. Tricyclics may have to be given in certain situations where none of the other drugs act. It is only the fourth line drugs among antidepressants as of now as per the guidelines. There are drugs like NDRIs, norepinephrine dopamine reuptake inhibitors, especially if there is lethargy, lack of concentration, sleepiness, lack of motivation during the daytime. Enhancing dopamine in the prefrontal cortex is an important priority. And for that, something like bupropion may be useful. And even ECT can be tried in extreme situations where the person is very highly suicidal or likely to develop it. Coming to the psychological management, whole lot of therapies including CBT, that is cognitive behavior therapy, identifying the faulty thoughts and correcting them. Interpersonal therapy, which focuses on correcting the interpersonal conflicts and issues. Mindfulness-based cognitive therapy, which focuses on helping the person focus on the present moment after detaching from the past and future. Positive psychotherapy, another psychological treatment, which focuses on increasing the inherent strengths of each and every human being. And finally, acceptance and commitment therapy, another psychological therapy which focuses on accepting the realities and within the limitations of that reality, promising oneself to move forward and moving forward without getting disturbed by what is happening in life. So apart from depression, there can be anxiety disorders also. I'll wind up in next 5 minutes. There are anxiety disorders also which can create problems. One of the commonest one is panic disorder. Now, panic disorder, the symptoms are very similar to myocardial infarction or hypoglycemia or hyperthyroidism or pheochromocytoma. It can mimic a whole lot of medical conditions. Again, most cases of panic disorder starts after an episode of hypoglycemia in several people, especially recently during the COVID phase. Many people had their diabetes precipitated by COVID attack. Many of them were put on oral hypoglycemic agents or even insulin. Sometimes, if an episode of hypoglycemia develops, the index episode of hypoglycemia produces lot of stress and fear and anxiety in them that they keep on anticipating the arrival of hypoglycemia. And even without hypoglycemia, even when the glycemic status is perfectly normal, sudden onset of palpitation, sweating, burning in the abdomen, breathlessness and a feeling of impending doom or feeling that you may become crazy, that kind of stuff. Similarly, another group of conditions called somatization disorders. We see a whole lot of cases in which young children or even adolescents, when school reopens after a break, they have severe vomiting. The vomiting continues for a long time, but by the time it is 11 a.m. or so, just like a switch has been pressed, vomiting completely goes away without any reason. All investigations don't reveal any kind of problems, gastric or otherwise. Again, in any stressful situation happens. So this is what is called somatoform autonomic dysfunction. Often it can be associated with medical illnesses. Again, there is another group of conditions called dissociative disorders. Dissociative disorders means the coordination between the body and mind is lost. We get a lot of consultations from Srijitra in which people with seizure disorder present with abnormal movements or convulsion kind of movements without any electrophysiological correlates. Again, in some cases of epilepsy, the symptoms are so intense and distressing to the patient that they keep on anticipating the arrival of seizures. So even without getting an electrophysiological seizure, they start showing abnormal movements very similar to seizures. But EEG does not reveal any abnormalities. The person is very fully aware and conscious about what is happening around him, unlike the case of epilepsy where he is not aware of what is happening around him. And neurologists give a diagnosis of PNES or psychogenic non-epileptiform seizures. In Malabar, the neurologists use the term NEAD or non-epileptic attack disorder. Physicians use the term pseudo-seizures for this, and WHO uses the term dissociative convulsions to refer to the same phenomenon. Two more things. Delirium. Delirium is probably the most common behavioral problem in an ICU setting. It is otherwise called ICU psychosis also. But I think as a person who had a fortune to take duty in ICUs during COVID time, after a very long time, probably after my house arrest, you could find that there is every reason why a person in an ICU can feel disturbed. No reason why he should not be disturbed, especially if people are dying and a lot of sounds and noises are there. We cannot help it, but of course, it's a really, really petrifying experience, especially if you have the misfortune of being in an ICU at least once as a patient on the other side of the table, of course. So, deprivation from sensory stimuli like light, inability to identify the difference between daytime and nighttime, lack of stimuli in the form of presence of loved ones, no contact with the external world, no way to access any kind of news or information about what is happening outside. These are certain scenarios where people can lead to a state of delirium. Added to this, metabolic abnormalities, infective issues, alcohol withdrawal, whole lot of things can contribute to this. Often in a state of delirium, there can be violent behavior. So at a time when there is extreme violent behavior, low dose of antipsychotics in the lowest possible dose for the shortest period of time should be given. Again, the choice of the drug should depend upon the comorbidities and the other drugs the person is taking. Finally, the last one is the behavioral and psychological symptoms of dementia or BPSD. Since dementia is on the rise, a word about that is also important. There are 6 categories of behavioral problems specifically seen in dementia. Number 1, most common one is apathy. A lack of interest and motivation in doing anything, just like a school child who is refusing to go to school. When woken up in the morning, the person with dementia will sit in a chair or in his own bed, refusing to do anything, including brushing his teeth. The most difficult condition to treat in dementia. Because, as I said, when a person becomes violent, everybody is frightened, but violent conditions are very easy to treat. But silent conditions like apathy, in which the person does not complain, does not show any kind of problems, from our point of view, is not producing any disruptive behavior, but it is very difficult to treat. Second is depression. The difference between apathy and depression would be in apathy, the person is not complaining. He's just sitting still, don't bother me. If you don't bother him, absolutely no problem. But in depression, the person will be complaining continuously that nobody gave him food, or everybody is trying to kill him, or things like that. Such kind of complaints may come. The third one, the most distressing symptom in dementia, is executive dysfunction syndrome. Because the executive function is totally lost. The frontal lobe problems can lead to disinhibition. So, walking without clothes, showing sexually explicit gestures, singing obscene songs, showing vulgar gestures to females, and all those things can be there. And this becomes a big problem, especially when the person was a very pukka gentleman till a particular phase of life. And after the onset of dementia, all these things are happening. The fourth BPSD is psychosis. The difference between psychosis in dementia and the psychosis in schizophrenia and other psychiatric disorders is that in dementia we get non-systematized, non-bizarre kind of delusions. Non-bizarre means delusions which are humanly possible. That a delusion that somebody is trying to take away the property, or somebody has entered into the house, or somebody is trying to poison, things like that. It's very different from most of the delusions which are seen in schizophrenia, where unbelievable, illogical delusions may be there. The fifth one is mania. Mania is very rare in dementia. Only 3 to 4% of people with dementia develop mania, but over religiosity can be a very classical side of mania, especially in dementia. And finally, anxiety. Anxiety happens in dementia patients who are well-read, knowledgeable about the illness. They might have read about the cause of the illness. They know that this is an illness without any cure. So for such a person, a diagnosis of dementia appears to be something like being stranded in a ship which is moving away from the shore, has lost all contact with the shore, and from very long distance you can see your near and dear ones, loved ones on the shore, but you are sure that you are never going to meet them ever again. What would be the state of mind of a person at that point of time precisely? Exactly, that is a frame of mind which a well-read, knowledgeable person who has been diagnosed with Alzheimer's disease is going to get. So panic attacks, insomnia, frustration leading to irritability outbursts, which translate into anger outbursts towards the caretakers, may be a very important thing. Going to the last 2 minutes of my presentation, a word about the emotional response of a person who has been diagnosed with a life-threatening illness. Elizabeth Kubler-Ross, very renowned researcher, has written a book called On Death and Dying. Says that a person who has been diagnosed with a life-threatening illness, his mental state goes through 5 stages. Number 1 is the stage of denial, in which you refuse to believe that you have got an illness. You want to take 2nd, 3rd, 4th opinions and go to different places to clarify whether the illness is a reality. Second stage is the stage of anger. You realize that you have got this illness. You are unable to believe it because your lifestyle was not in such a way that you could get this illness at this stage. And you may see your neighbor who had all sorts of lifestyle abnormalities happily continuing to indulge in alcohol without any sign of any of these illnesses. That creates a problem. This anger outburst may be manifesting towards the doctor, towards the caretakers, the relatives, and whoever is in the vicinity of the person. Third phase is bargaining. The person starts bargaining whether he will be surviving for a particular period of time so that some of his desires can be fulfilled. Will I live for 1 year more so that I can see the marriage of my daughter? Will I survive for 6 months more so that my son can get a job and I can peacefully pass away from this world? These kind of bargainings. One huge problem which happens during this stage is that when the battalion of consultants ranging from the unit chief to the house surgeon comes for rounds in a teaching hospital, the patient may be asking the same question to every person at the group. He'll ask the question to the unit chief, who will reassure him. Then it goes to the assistant professor, then to the PG, then to the house surgeon, everybody. And we need not feel offended about that phenomenon because it's the response of a frustrated, helpless mind. Fourth stage is the stage of depression. Depression with all the features of the Anticodes criteria which I mentioned may be surfacing. And finally, the last stage is the stage of acceptance. So how to guide a person right from the stage of denial to the stage of acceptance at the earliest is the challenge which a medical professional has to face. Once again, thanking the organizers for this very great opportunity. Thank you very much.